So the first one that we're going to start off with is on epidemiology and role of AI in diabetic retinopathy. Our esteemed speaker is Dr. Rajiv Raman, senior consultant at Sankara Nethralaya in Chennai. He also heads the diabetic retinopathy project at Sankara Nethralaya. So,
thank you. Thanks for including me in this symposium. It's really, every year I think one national symposium on diabetic retinopathy happens. So next couple of minutes I'll be talking about epidemiology. Both topics are a bit different, but I thought I'll combine both to cover in this epidemiology and role of AI in diabetic retinopathy. So let's start with epidemiology, and definitely diabetes is an epidemic. It's a global epidemic today. And International Diabetes Federation did say that the number of people with diabetes more than 20 years, 2045, every 8th person will have diabetes. And the worst part is that 1 in 2 really don't know that they have diabetes. That means there is an equal or more burden of pre-diabetes in the country. And these are the top 10 countries where we have maximum people with diabetes in the world. And combined China, India, and US, nearly half the people of diabetes reside in these 3 countries. So this definitely shows that diabetes is an important problem. Last year we had this, the INDIAB study, the national prevalence of diabetes and pre-diabetes, and we do have today about 101 million people with diabetes and nearly 136 million people with pre-diabetes today in our country. And they also found that there is something called as epidemiological transition in diabetes, which is seen. That is, the people who are living in the economical developed states, in the lower socioeconomic status, unlike previously we used to believe that diabetes is a disease of higher socioeconomic status. Now in these developed states, it is in lower socioeconomic, and surprisingly, even in less developed states, you still have diabetes, urban, rural, nearly equal, more in the higher socioeconomic status. Very recently, we conducted this multicentric nationwide study called a Smart India study, and lot of evidences today I'll be sharing is from this study. And one thing which came out is that prevalence of undiagnosed diabetes seems to be equal, both urban and rural area, about 6%. And what was surprising that nearly 75% of people had a suboptimal glucose control. And worse was that HbA1c more than 9, 40% of them had. That means there is a real big burden of uncontrolled diabetes in India too. We came out with this publication on prevalence of diabetic retinopathy, the national prevalence of diabetic retinopathy. I'll share a small video which gives the key messages from this paper. Urban problem, where both rural and urban area having equal. We came out with some priority areas that you need to screen. You need to do a differential screening. We have to prioritize the states where we really want to work more. We identified people more than known diabetes, people more than 40 years, both urban and rural areas should be covered. And today we have a staggering 3 million people more than 40 years with vision-threatening retinopathy. So this study came out with some very hard facts which we need to really think of when we think about our country. And more recently, last couple of weeks back, we came out with this national prevalence of visual impairment and blindness because of in people with diabetes. And again, 1 in 5 diabetes per person suffering from diabetes has visual impairment. Now that's again really very big number. And the higher prevalence of visual impairment is because of in those who have ungradable images. Again, meaning cataract still continues to be one of the leading cause of visual impairment in people with diabetes. And we did find that in gradable images, people with diabetic retinopathy seems to be important, especially people with known diabetes. And socioeconomic status also came out as one of the risk factor. The lower socioeconomic people had more visual impairment. We also went ahead calculating the cost of blindness and visual impairment in India. And again, staggering numbers. I would just draw your attention to the lost economic activity. That's nearly 5 times the health budget of our country. So definitely diabetic retinopathy becomes an important disease which we need to tackle. One thing which again we found, though we had diagnosed so many people with retinopathy, only 10% of vision threatening retinopathy actually took the treatment. So this was really surprising, because this study, we did treatment free of cost. We gave everything, but still 10% came, and this prompted us to try to look at what is the treatment seeking behavior regarding diabetic retinopathy. So definitely it is very poor, and there's poor understanding of diabetes and eye. There's definitely one factor they say is to one treatment may be free, but later we have to pay some cost and prohibitive cost. And we took the ophthalmologist perspective also, and we found some of the barriers there too. So we need to change this treatment seeking behavior regarding retinopathy. This just to summarize. I'm not going into individual epidemiological risk factors, but summarizing the lessons we have learned and what can be the possible policy implication. So as I told you, 75% of the people have suboptimal control, and definitely we need to address this in some way. 1 in 5 people have visual impairment, and we have so many of people blind, and we need to now still prioritize cataract surgery. That is important, because cataract comes out to be one of the leading cause of visual impairment, even people with diabetes. The prevalence of vision-threatening retinopathy is about 4%, and we have 3 million people of vision-threatening retinopathy. We really don't have so many doctors screening and treating. This is an urgent need to identify and treat across the country. There is heterogeneity in distribution, so definitely we need to prioritize the diabetic retinopathy pathways in the states. Again, differentiating it into high epidemiological transition zones and the lower ones. It is both urban and rural. More than 40 years, people should be screened for diabetic retinopathy. And again, it is more common in people with known diabetes. As I told you, it's only 6% prevalence in newly diagnosed. So if we target for screening people who are already having diabetes, I think that will go a long way. This I have already told. And one exciting thing we did in this study, all these images we also used AI to screen. And we saw that the performance of, so the first grading was done at 3 levels. So we had 3 graders grading, and then we also had an AI grading, and the performance of both was nearly same. So we suggested that a physician-based DR screening, AI integration can scale up the screening really in our country. Targeted mydriasis or a AI-assisted prediction of gradability, that also we proved that if we can say that the image would be non-gradable, and we ask the technician to retake the image, the chance of a gradable image significantly improves. And only 10% were compliant. That again attests the fact that we need greater health literacy around diabetes, diabetic retinopathy, and sight-threatening retinopathy. Coming to the risk factors, there are a couple of risk factors which are modifiable and non-modifiable. And we went ahead looking at all the risk factors in South Indian population. So we looked into SN Reams, the Madras Diabetic Retinopathy Study of MV Diabetes, the Arvind Comprehensive Eye Study. We collated all these 3 data and came out with a machine learning algorithm which could rank the risk factors. So we had cures, SN Reams, ADRES, and SN Reams 2. And then we used machine learning techniques to rank these risk factors at the level of importance. And we came out with the AI algorithm that just putting these risk factors, because it's next to impossible to screen 106 million people with diabetes in our country. Probably a staged approach using risk factor, and those who are at more risk, doing a screening from them is a solution at the community level. Coming to just concluding the role of AI in diabetic retinopathy. So we have now some established role of AI. Definitely AI-based diabetic retinopathy screening is something which is now attested by not only VRSI, AIOS, even recently by RSSDI and American Diabetic Association. So this is something which should be used so that we can screen more people with diabetes with existing manpower. The risk factor engine for diabetic retinopathy is something which is very important for a country like ours, where the load of people with diabetes is very high. If we can triage the non-gradable images, because using non-mydriatic cameras, nearly 30% of the images are non-gradable. If we can triage them and try to improve this to some level is something which AI has been doing now. Diagnosing diabetic macular edema on OCT is again something which is it has been already established. And Professor Ursula has also tried looking at various fluids compartments in diabetic macular edema with a greater success. She worked on AMD and DR both, and that's also something which is already available. There are emerging role of AI in diabetic retinopathy care, predicting thicknesses from retinal images, identifying imaging biomarkers. People are trying to identify various other systemic disease to some success, identifying the treatment response after anti-VEGF or a steroid, and can we predict the progression of diabetic retinopathy is something which has really worked out, and probably we'll see this sooner than all others. This is the very recent work which was led by Professor Tin Wong, and we were happy to be part of it, where we made a deep learning algorithm which can predict the time to progression of diabetic retinopathy. So I would encourage you all should read. You'll see some images with no retinopathy at baseline. AI predicted even the location where the microaneurysm will develop, and after 4 years we had microaneurysms in that area. So this, we can classify people into high and low risk of progression. Not go in detail, but newer networks were used as far as AI is concerned. The techniques called as transfer learning was also used. And we had this data where we had patients followed after 4 years, images on both sides, and we could make a differential personalized interval. This is the performance across various external data set, including the Indian data set, all of them showing a very promising result. It also used generative AI at the end so that it could even give advice what the patient should do. That's the last slide. So on our Indian data set, we could increase the screening interval to nearly 32 months. That means if you use this AI one, rather than telling every 1 year, we can call them after every 2.5 years. And the delayed detection rate was only 0.37%. And this could reduce the frequency of screening by nearly 62%. I think we'll get more and more of these algorithms with the newer AI networks, and that will really reduce the work of screening this 101 million people with diabetes. Thank you very much.
Thank you, Rajiv. It's very elegant presentation, and the work you are contributing towards the literature is really commendable. I'm interested in a few things which you have talked about, in that pre-diabetics is really a great burden which we are missing. We cannot detect. What are your suggestions for weeding out all the pre-diabetics?
See, as an ophthalmologist, one good thing is that pre-diabetes, though there are Dr. Raj Lakshmi group from MV Diabetes, they have looked into prevalence of diabetic retinopathy in pre-diabetes. And one good thing is none of them have sight threatening. It only comes with mild type of, or sometimes moderate, not more than that. But from a physician point of view, I think everybody more than 30 years is a potential diabetic. And if a yearly blood test is done, we can, and if there is a strong family history, again, Dr. V. Mohan has this scale, objective scale, where you can put in all the parameters, and that will give whether you have at a high risk of diabetes or low. Using those scales and then doing a screening is something which can really pick up these pre-diabetes.
Yeah, and in this SMART study, you observed 75% of suboptimal control, which is very, very dangerous.
It's very dangerous.
What are your suggestions to tackle it?
I think it all boils down to the end. Though we have 4 billion people with sight threatening, only 10% came for treatment. So I think health literacy awareness is something which has to be hit hard.
Media. We should use the media for propagation. Okay, thank you very much.